So, good morning to everybody. I am coordinating this session on behalf of President Dr. Sushma Bhatnagar because she's extremely busy in the current COVID situation. Uh, Interventional pain relief is very, very important. I remember many years ago, my father had trigeminal neuralgia, and he really benefited from an RF lesion. So we have a very eminent speaker today, Mayank Gupta, a brilliant academic career with a gold medal in MBBS, MD, then the National Fellowship in Palliative Medicine and Fellowship in Pain Medicine. Currently, he's the Associate Professor, Department of Palliative Medicine and Supportive Care at the Kasturba Medical College in Manipal, and is the lead for the Division of Chronic and Interventional Pain. He's been part of a number of projects, the CTC project. Recently, there was a training for master trainers for palliative and geriatric care by the NHSRC, and he's involved in various committees of the Government of India, and was also involved with, setting up the state palliative care policy in the state of Uttarakhand, where he was before he came here. Mayank is going to basically give empirical evidence. Is there any role for combining chronic pain and interventional pain services in a palliative care scenario or a palliative care service in a hospital setup? So, Mayank, over to you.
Thank you. Thank you so much, sir, for the warm introduction. Let me share my presentation. Is my presentation visible, Nisha?
Yes, it is. Go ahead.
Good morning to all of you. Today I have been given the task of presenting what is the evidence available for integrating chronic and interventional pain services in palliative care services. So first, my disclaimer, the primary focus of this presentation would be to explore the evidence-based interface between the palliative medicine and interventional pain services. My presentation does not intend to provide a detailed review or indications of individual pain interventions, which I am sure Dr. Mahesh would have excellently covered in the previous session last week. Instead, I would like to highlight the need and some of the practical aspects from my personal experience of how to establish and integrate interventional pain services in palliative care setting. So the overview of my presentation is that why is it important to integrate interventional pain services and palliative care? What is the evidence available? Which interventions go better when it comes to the evidence level of evidence available and how to integrate? So before that, I would like to go to a very common case vignette, which I'm sure every one of us must have seen in our palliative care OPDs. So Mr. R is a 42-year-old gentleman with advanced pancreatic cancer for best supportive care. He presented with severe abdominal pain of numerical rating score of 8 to 10 out of 10. It was mixed nociceptive and neuropathic in nature. The pain was so severe that it was interfering with every aspect of his life. And the family claimed that they were very much distressed by his constant moans due to pain. He was on tablet morphine 180 milligram per day, paracetamol 4 gram per day, gabapentin 1200, duloxetine 80, and flupertin 300. But still the pain was inadequately controlled, and he was troubled by the constipation and somnolence due to the opioids. He had frequent late night hospital visits to get injection diclofenac for his pain. So the first time he came to my OPD, he said, I have accepted my cancer and my fate, but cannot tolerate this excruciating pain. I know that nothing much can be done about the cancer now, but can you please do something about this pain? So can I please ask the forum to put it in the chat box, what would they like to do in Mr. R? Dr. Arun, will you help me in?
Sure, there is nothing at the moment. I'll let you know, sir, whenever it comes. Requesting everyone to please put your thoughts on the chat box about the case. Right, it's coming. So people are writing about celiac plexus block. Everybody is writing celiac plexus block.
Okay, so my job is easy.
Mesenteric plexus radio ablation. Someone has written.
Good. Okay.
Yeah.
So why there is a need to integrate the chronic and interventional pain services into palliative care? The first and foremost is the magnitude of the problem. We all know that about 50 to 60% of the patients with advanced cancer or those on anti-cancer treatment suffer from moderate to severe pain. And considering the incidence of cancer to be about 18 to 20 million, that means on an average every year 10 million cancer patients suffer from moderate to severe pain, and about 4 to 5 million of patients die due to cancer with moderate to severe pain. Although ubiquitous, but certain cancer types have more prevalence, for example, bone, head and neck cancers, genitourinary and gastrointestinal cancers. We all know that the oral opioids or pharmacological management forms the mainstay of cancer pain management, and that has been promulgated by WHO in the form of analgesic ladder. This is because the oral opioids have a unique safety and efficacy profile when they are given round the clock and with attention to detail. However, since its inception in 1986, no randomized controlled trials have been conducted. Despite that, because of decades of experience, we do know that WHO LADA does provide good to satisfactory analgesia in vast majority of the cases, as has been shown by 3 systematic reviews till date, covering a span of 13 years, 22 years, and 28 years, according to which WHO LADA is effective in managing pain in about 70 to 90% of the patients. However, to note is that these systematic reviews have also acknowledged a limited subset of patients fail to get adequate pain relief with the pharmacological management. Besides the WHO ladder, a number of international efforts have been taken to recognize the importance of cancer pain and the need to manage it adequately. The first and foremost was the recognition of pain as the 5th vital sign. Then the United Nations Committee on Economic, Social and Cultural Rights advocating pain management to allow patients to die with dignity. And the Declaration of Montreal declaring access to pain management as a fundamental human right. But despite all these international efforts, there remains a subset of patients to the tune of 10 to 30% in whom either the pharmacological management is ineffective or it leads to intolerable side effects, and the disease modifying treatments such as chemotherapy or radiotherapy is either not indicated due to the advanced cancer or poor performance status, or it is not effective in managing their pain. Then what about these patients? So these patients have traditionally been suffering from moderate to severe pain, not just the physical pain. This unrelieved pain leads to poor performance status, reduced levels of hope, and the mood disturbances in the form of anxiety and depression. So in these patients, the interventional pain management provides a good bridge when both the pharmacological management and the disease modifying treatments have been inadequate in managing their pain. Not just reduction in the pain scores, the intervention such as celiac plexus block has been found effective in improving quality of life in all the dimensions, be it physical functioning, social functioning, emotional functioning, or general health perceptions. This was regarding the refractory cancer pain which fails to get adequate pain relief with pharmacological management. However, there is another subset of cancer patients who do not have either a background pain, who have intermittent or frequent breakthrough pains or incident pains. So for example, patient with oropharyngeal carcinoma presented with frequent episodes of odynophagia, even triggered by deglutition of saliva. So in such cases, we know that the frequency of the breakthrough pains is so much that giving oral opioids as the breakthrough medications is every time is not feasible, and increasing the background analgesia leads to more of side effects in the form of somnolence, nausea, constipation. So in such patients also interventional pain management comes in handy. It helps in maximizing the pain control and quality of life, whereas minimizing the treatment burden and side effects due to oral opioids when the background pain is not there or it is very well controlled. So for example, I was discussing about oropharyngeal carcinoma. These patients present with frequent base of the tongue, tonsillar fossa, and pharynx pain, triggered even by deglutition of saliva. So in such cases, pulse radiofrequency of the glossopharyngeal nerves does an excellent job in reducing the breakthrough pains. It has been found to reduce not only the background pain, but the odynophagia, reduce the incidence of nausea due to the oral opioids, and lead to improved sleep. So this was regarding when the oral opioids are either not effective or they lead to intolerable side effects. But one should not forget that there is a majority of Indian population who lives in rural and semi-urban areas where the oral opioids are not easily accessible. And during the challenging times such as during this COVID pandemic, when there are lockdowns, when the patients are not able to visit the tertiary healthcare centers or cancer care centers to get their refill of oral opioids available. So these patients, they remain at home suffering in pain because they cannot get the oral opioids, which was effective in managing their pain. In such cases, a number of interventions, for example, sphenopalatine ganglion block, given through transnasal route and same being taught to the caregivers, can be easily applied for, and it is easy, effective, and cost-effective method to manage head and neck cancer pain. Sphenopalatine ganglion block is an excellent block because we all know that all the efferents and sympathetic nerves which are going from the face, their first relay center is the sphenopalatine ganglion before they go on into the central connections. So, and sphenopalatine ganglion is easily accessible at the level of middle turbinate. It's just few millimeters away from the nasal mucosa without any intervening bone. So a local anesthetic applied at the base of the middle turbinate, it helps in reducing the background as well as the frequent breakthrough pains in patients with head and neck cancer pain. Because of all these indications, a number of authors and people have, and expert opinions have advocated modifying the WHO analgesic ladder to include the fourth step, that is the interventional pain management. And as we all know that the WHO ladder is the step 1 first. Similarly, for interventions, if you think that the patient is eligible for intervention even before the step 3, there are indications to try intervention pain management and not only as the last resort or the salvage therapy. Because of this, the NICE has, in its guidance on supportive and palliative care for cancer patients, has also advocated that each cancer center should have a pain specialist with expertise in nerve blocks, neuroablations, and neuromodulation techniques. So considering all these needs, it has been advocated to integrate pain as well as interventional pain services with a goal of delivering coordinated and consistent services to those in need. And the advantages of this integration will be multifold, because there are a lot of pain physicians who are already performing interventions, but in an uncoordinated fashion for cancer pain. Whereas there are some palliative care physicians working in the same geographical area, but they have difficulty in accessing the interventional pain management for their patients in whom the opioids are either not effective or leading to side effects. This is because there is a lack of integration between the two services. Therefore, an integrated model will help ensure easy and timely access to address the unnecessary suffering. And secondly, we all know that pain in cancer patients is not always cancer pain. They do suffer from non-cancer etiologies like osteoarthritis, disc prolapse, which might be better addressed by the pain physicians. So a broad multidisciplinary approach comprising of pain specialist, palliative medicine specialist, psychotherapist will rope in expertise with the common intention of providing adequate and timely pain control, which has been found to impact the quality of life, outcomes of curative treatments, and in fact increase cancer survival. It allows the patient to live as actively as possible till the end. Now coming on to the evidence for integrated pain and palliative medicine model, there is a scarcity of literature about the interface between the two services, with only 3 national surveys being published since 2002. The first one was published in 2002 in Palliative Medicine, looking at pain management services utilization in palliative care services. So the postal questionnaire was sent to 280 members of Association of Palliative Medicine UK. The response rate was about 80%, indicating that yes, this is an issue of considerable interest. What the survey results brought out was that there was marked underutilization of pain services. The pain services were available only as required basis and not regular basis to about 80% of the respondents. Although most had consulted a pain physician in the last year, but only half of the time they had a joint consultation, meaning there was a fragmented approach. The palliative care physicians were looking at the patient separately, and when they were not able to manage the pain adequately, they referred it to the pain physician, but there were no joint consultations in between. More than 50% consulted just less than 4 times per year, that is less than once in 3 months. 20% of the palliative care physicians desired it would be helpful to have more frequent anesthetic inputs for their patients. Almost all the interventions were easily available except very few advanced interventions like cordotomy. The most significant barriers to availability of pain management services was lack of formal arrangement, as most of the pain physicians were working as out of office working hours. There was geographical isolation, and some places the pain management services were not available. Lack of expertise available, as well as the lack of interest, as the number of pain referrals were not very much, so not a number of anesthetists were interested in looking after cancer pain. What's more important is that only a minority of palliative care physicians agreed that the pain physicians have a role in medical management of pain, falsely perceiving them as technicians. In the last lecture, Dr. Mahesh Menon was talking about him being called by a number of terms by different staff of the hospital. So one of them most common is needle jockeys, which the pain physicians are not. They are also trained in management of pharmacological management of not only pain but other symptoms as well. So it's very important to have an interdisciplinary understanding of what these services can be provided by each other. The same questionnaire was then the same questionnaire-based study was then conducted and published in 2017, in which questionnaire was sent to palliative care physicians in India. Most of the respondents had encountered moderate to severe complex pain syndromes in more than 50% of cases, and about 60% of them felt that a pain specialist input would have been better in managing these difficult to manage pain. Contrary to the UK survey, the palliative care physicians in India, they thought that the pain physicians, they have a role in medical management of pain. 50% felt that there is a need for their input on regular basis, and 95% thought there is an integration of pain and palliative care. This might be because a number of palliative care physicians in India are from anesthesia or pain background, whereas in UK it's a separate subspecialty in itself. However, the pain services were not available to 41% of the palliative care physicians. We have looked at one side of the coin, that what the palliative care physicians think about the requirement of pain services. Another survey, which was published in 2007, again in palliative medicine, looked at how the pain specialists perceived their need for managing cancer pain. So the questionnaire was sent to 170 pain specialists. It also reiterated that there is an underutilization of services, joint consultation of job hours to accommodate palliative care referrals. However, those who had formally allocated time for palliative care had significant increase in referrals. And unlike the palliative care physicians, majority to the tune of 76% felt that yes, they have a role in medical management of cancer pain also. So not just the needle jockeys or the technicians, they do have a role in medical management. Most of them were doing most of the interventions. However, they found a difficulty when discharging a patient with a neuraxial catheter to the community, because there was lack of training among the community palliative care teams in managing a case with neuraxial catheter in situ. So that there is a need of interdisciplinary learning, so that there is a smooth navigation of patient care from hospital to the community and vice versa. So yes, these are there's a need for integrating pain and palliative medicine services, but there are significant barriers such as fragmented approach, split responsibilities. So the pain and palliative care physicians are looking after patients separately in an uncoordinated fashion, leading to duplication of efforts. There's a lack of infrastructure and lack of insurance coverage for both palliative care as well as pain interventions. So though these interventions are effective in managing refractory pain, most of these are underutilized or kept only at the very end of life, when these interventions may not be very effective. And this leads to an uncontrolled pain and a significant subset, that is we are to integrate these pain and palliative care services to have a better interprofessional understanding of these skills, and to provide anesthetists with special interest in cancer pain adequate time and resources from the administration or management side, so that they can have more better involvement in the multidisciplinary discussions at an early stage and not at the very end. So Dr. Mahesh and I am talking about interventions. So what are these interventions? These are minimally invasive procedures and a specialized branch of medicine which looks at diagnosis and treatment of pain. They work either by targeted delivery of drugs such as local anesthetics or steroids, or by neuroablation, which may be chemical, thermal, or mechanical, or by neuromodulation. They can be classified on the basis of intention, whether it is a diagnostic or a therapeutic intervention, the nervous system targeted, whether it's a somatic or a sympathetic nervous system, or modality, whether it's just a targeted delivery of local anesthetic or a neurolytic block such as celiac plexus neurolysis, or a neuromodulation such as spinal cord stimulation, or others like vertebroplasty and kyphoplasty. There are a lot of interventions which I won't go into detail, and I'm sure Dr. Mahesh would have excellently covered these interventions. When it comes to the evidence available for these interventions, only two interventions, that is the celiac plexus block and neuraxial administration of local anesthetics and opioids, they have a positive recommendation. That means the level of evidence is high to support their use, and two evidence-based clinical practice guidelines. One, the most recent one by ISSP and Iapc, which was published in 2020. However, a lack of evidence for other intervention does not mean they are not effective. It's mere that the evidence, we need to do more of research and bring out more of studies so as to show that yes, they are effective. Now coming on to the celiac plexus block, the first Cochrane review, which was done in 2011, it looked at 6 RCTs published till date. What it found was that the celiac plexus neurolysis was very much effective in reducing the pain scores at 4 weeks, or relief were not very well sustained at 8 weeks. However, they lead to significant reduction in the consumption of opioids and opioid-related side effects, and hence they concluded even though the pain relief is not that significant numerically and statistically, the fact that they do result in significant reduction in opioid doses and opioid-induced side effect, which justifies its use. Another meta-analysis, which was published in 2014, came up with the similar findings that the pain relief was significant at 4 weeks, which was not well maintained at 8 weeks. However, the reduction in opioid dose was very well maintained till 8 weeks post-block. So celiac plexus block is effective. It is safe when done in appropriate patients by those who are appropriately trained to do such interventions. However, there have been few instances of section of the aorta or paraplegia also. So it is very important that all the attention to details are strictly adhered to while doing these interventions. Celiac plexus neurolysis has been found not only in reducing the pain or reducing the opioid doses and opioid-related side effects, but it has been found to have significant impact on mood in terms of reducing anxiety and depression among pancreatic cancer patients and improving survival in these patients. Now coming on to neuraxial analgesia, which is again a very useful modality which provides selective pain relief while reducing the opioid-induced side effects. A number of drugs have been used. However, only morphine and ziconotide only for neuropathic pain are FDA approved. In those patients who have a good good relief with the trial of Neuraxial Analgesia. We can put an implantable, which may be a programmable or a non-programmable depending upon the affordability and the prognosis of the patient. The advantage is that it results in significant reduction in doses of opioids. However, when it comes to IDDS, that is implantable drug delivery system, only morphine is FDA approved and the cost is usually prohibitive in developing countries. I'm sorry for the font, something has gone wrong with the font. However, the two systematic for Neuraxial Analgesia for cancer pain. Neuraxial IDDS and various other modalities of neuraxial delivery of opioids have been found to be effective, but the level of evidence is weak in terms of only case series, case reports, retrospective or prospective cohort studies. So the recommendation is weak for their use. This is a more recent, which was published in 2020. This is a multi-centric prospective trial which looked at the response of cancer patients, 1,400 cancer patients to IDDS, implantable drug delivery system. And it has been found to not reduce the pain scores as well as improve all the dimensions of quality of life, which were persistent at 6 months post-treatment. And a number of cost-benefit analyses have shown that at 3 to 6 months, the cost is the IDDS scores better when it comes to cost effectiveness. The only randomized control trial published till date comparing IDDS with conventional management was published in 2005. It was a very well designed study with a proper randomization and allocation concealment. It showed that IDDS was effective in reducing pain scores at 4 weeks. However, the effects were not very well maintained at 3 months post-delivery. However, it was effective in reducing the opioid-related side effects at both 4 weeks and 12-week study points. What's more noticeable is that a statistically significant number of patients, that is to the tune of 60%, were alive at 6 months compared to only 32% in the conventional management group. They are again effective, they are safe when done and appropriately with attention to detail and by those very well trained in using these interventions. However, a number of minor and major catheter related, pump related complications may happen. So attention to detail is very well important. Now coming on to vertebroplasty and kyphoplasty, which is recommended for pathological fractures due to either spinal metastasis or multiple myeloma. Two systematic reviews looked at, one looking at 59 studies, but majority of them were either case reports or case series. So kyphoplasty has been found to be more effective and safer compared to vertebroplasty. Both have been found to reduce pain relief at up to 6 months post-intervention. However, there is a risk of serious complications requiring neurosurgery in about 5% of the patients, with the risk factors being the intervention being done under general anesthesia or use of more than 4 ml of cement. Now, the destructive procedures now have a historic role, except for sympathectomies and maybe cordotomy in the Western world. Previous to the use of opioids for cancer pain, they form the backbone of cancer pain management in the form of cordotomy, myelotomy, cingulotomy. A systematic review which looked at all the neurodestructive procedures for cancer pain found 120 papers. However, majority of good quality papers such as RCTs or very well controlled trials were for sympathectomy, that is celiac plexus or superior hypogastric neurolysis. All other interventions had only case reports or expert opinions, and majority of them were for cordotomy, which has been found to be effective and safe for unilateral cancer pain, which is not responding to pharmacological management. Other interventions such as sacral neurolysis and spinal cord stimulator, they have a very weak evidence in the form of case series and case reports. However, as I have already said, that lack of evidence does not mean they are not effective. So spinal cord stimulator has been found, a Cochrane review looking at spinal cord stimulator for cancer-related neuropathic pain found it to be effective in reducing the pain scores and improving quality of life. However, there were case reports of major side effects such as CSF leakage or displacement of the electrodes or a system failure needing removal of the spinal cord stimulator. IV lignocaine infusion is effective in patients who are suffering from neuropathic cancer pain. When pharmacological management is not very effective in controlling those pain, especially in those with chemotherapy-induced neuropathic pain. It has been found to be effective in about 50% of the patients. There were questions about paravertebral block in the last session. It has been found to be effective in reducing the post-mastectomy pain syndrome. However, the level of evidence is weak in the form of only case series and one RCT with numerous methodological flaws. Now we have looked at why the interventions are important. What is the level of evidence available for integrating them with the palliative medicine services? Which interventions score better when it comes to a level of evidence available? The traditional, now coming on to the timing of these blocks. The traditional model is that the intervention are being asked for when all the other pharmacological agents have failed at the very end of life. So this has led to significant underutilization of these services. And what about when there is a significant difference between the background pain and the breakthrough pain, as we have discussed in patients with oropharyngeal cancer, or patients who have a localized pain requiring large doses of medication leading to side effects such as somnolence, or patients with somatic pain confined to a few dermatomyotomes, which may be better addressed by interventions. So in such cases, salvage therapy may not be the best approach. And patients being referred only when as a last resort, it may not be a very, when they may not be very effective because the disease has already metastasized to multiple sites. Patient develop other psychological, social aspects of total pain. They have a poor performance status, and hence shifting them to the hospital for the intervention may not be very feasible, or the interventions may not be effective or indicated because they have developed coagulopathy due to liver metastasis, or they may have gross ascites, for example, patients with abdominal cancers. If you look at the predictors of efficacy of the blocks, so a better performance status, lower tumor markers, shorter pain duration, and lower opioid dose, which are frequently seen in the early stages of the cancer, they are the predictors of better efficacy of neurolytic celiac plexus block. So nowadays, celiac plexus block is considered much earlier, maybe when the step 1 or the step 2 has not been effective in managing the patient's pain, and not only as the last resort. Not only celiac plexus, but there is emerging evidence that a number of other interventions may be better, probably earlier on, and they may prevent or slow the spiral of increasing pain and opioid consumption. They lead to better pain control and much earlier pain control, thereby avoiding the hysteresis or time lag associated with titration of the oral opioids. They lead to significant reduced consumption of opioids and opioid-related side effects, and hence improve quality of life and improve survival, as has been shown for celiac plexus block and neuraxial analgesia. They not only reduce common opioid side effects such as somnolence and constipation, but they may have a potential to reduce long-term opioid effects, particularly in cancer survivors, such as opioid-induced hyperalgesia, endocrine abnormalities, mood changes, and cognitive dysfunction. So this was a prospective randomized multi-center study which looked at performing neurolytic block as an early intervention, that is group 1, or as a traditional or salvage therapy, that is when all the other interventions were not effective, as group 2. What they found was that the early intervention was very much effective in reducing the pain scores, which were persistent up to 5 months after the block, improving the overall quality of life, which were persistent again up to 5 months after the block, improving the overall symptom scores other than pain, for example, sleep, anxiety, depression, physical functioning of the patient, emotional functioning of the patient, cognitive functioning of the patient was better and persistent up to 9 months after the block. social functioning. They were able to socialize much better than those who were on conventional management. It leads to reduced opioid consumption and opioid related side effects. Other authors have also shown similar findings that early neurolytic sympathetic blocks such as celiac plexus or superior hypogastric plexus block leads to reduced pain, reduced opioid consumption. Most recent article published by Dr. Sushma Bhatnagar looking at the impact of early intervention, not just the celiac plexus block, but a wide range of interventions for cancer patients. So what they found was that early interventions were effective in reducing the pain scores and improving the performance status of the patients, which were persistent at 1 month in some. So these interventions, when performed early, they lead to longer duration of pain relief. They are inexpensive when we look at the long term. For example, patients surviving 3 months or 6 months after the intervention. They avoid repeated visits to a pain clinic or the hospital. Prolonged hospital stay is usually not required for majority of these interventions. And patient can remain at home pain-free even when the medical help is scarce or the opioids are not freely available. Now, after going through all this evidence, there's no point at looking at the evidence without, if we cannot translate it into practice. So I'll have, so the next few slides will look at how to integrate pain and palliative care services. In this, I'll be majorly speaking from my personal experience at starting new services in a medical college and then incorporating chronic pain services in a well-established palliative care services. So when we are starting new services from scratch, when there may be just one palliative care physician or one pain physician starting these services, he's looking after both the palliative care as well as the chronic and interventional pain. So what's most important is to get an administrative support, because only after administrative support and the institution making pain and palliative care their priority, the system is more sustainable. And what we did was that we did not wait to start these services only when we have a fluoroscope or an ultrasound machine or a RF generator, because that ideal system usually does not happen. So we started what we had. We started delivering these services, let our work speak for itself. And we kept on sensitizing both the healthcare workers as well as in the community about the need of palliative care and pain management. And with time, we led to expansion of the services and team building. So we had the support of the head of the department. So when I talk about administrative support, it's always better a top-down approach, because just the support of the head of the department may prove like an Achilles heel. If the head of the department changes and he is not very much supportive of the services fall apart. What we realized was that there was no extra space available for pain on palliative care services. So, but the PAC clinic, pre-anesthetic checkup clinic was very big, and the space was underutilized. So we just had a partition and started our pain services. We gave it a formal name. We had a formal inauguration to let the people know that yes, new services are being opened. What does the services entail, whom to refer, and what do we provide them? And as the time went on, we started deepening our roots, started with cancer pain and went on to manage non-cancer pain and so on and so forth. We kept on awaiting the health, improving sensitization, not only among the doctors, the nurses, the MBBS students. We had an opioid workshop done so that the oral opioids could be can be made available in whole of Uttarakhand and in our institute. We had an international update and involved the Indian Medical Association so that we can sensitize all the healthcare professionals working outside our institution. And while all this managed by one person, we kept our services. There was a simultaneous delivery of the clinical services in the hospital. We were seeing patients in the casualty, in the OPD, wheresoever we get a reference. We were performing interventions. Sometimes I had to do interventions at 6 a.m. in the morning when the fluoroscope or the ultrasound machine was free. Not just the hospital and the healthcare professionals, we did a wide sensitization within the community, both in certain groups such as the RSS group. We did role plays, nukkad nataks to improve the sensitization among the healthcare professional that yes, palliative care is everyone's business. It's their right as well as their responsibility. We had newspaper articles covering about the earth pain. And when we go out in the community, it's very important that we just not preach the patient, preach the people, but we also provide our services to those who cannot come to the hospital settings. So as is visible in one of the lower photographs, this is how the roads in Uttarakhand usually are. So it's a very difficult terrain, and the patients are living in very bad conditions and cannot be transferred to the hospital. So we had our emergency minimal supplies available with us so that we could do wound dressings, we could do bed sore dressings, we can empower the caregivers how to take care of the patient, and simultaneously taking time to provide continued clinical services within the hospital. So this is a co-development model that we were sensitizing community healthcare professionals, providing services in the community, as well as providing services, making sure that the services were not being hampered within the hospital. But everyone has no model is foolproof. We do had our drawbacks, as I already discussed, that it's important to have administrative support from a top down rather than just at one level, which may prove to be Achilles heel. But it's very important that we learn from our failures and keep on improving our approaches. So now looking at integrating chronic pain services in a well-established palliative care services. This is much easier because the need is already felt there. So we started chronic pain services in a well-established department under an able leadership, and we did that at a time when they were transitioning into further subspecialization into renal palliative care, ICU palliative care, pediatric palliative care. So at that time, the chronic and interventional pain services was made a separate division under the umbrella of palliative care services. But yes, we did our sensitization and awareness sessions. We were started doing interventions as and when the referrals came. And now we are looking at further subspecialization, going away from chronic pain services to start more pain services, such as an orofacial pain services, chronic postoperative pain services. So when we look at integrating pain and palliative medicine services, it's very important to have a co-location of these services because it helps in interdisciplinary training, education, and it facilitates knowledge exchange. So for example, it's very important for fellows who are doing pain fellowship to learn about basics of symptom management and palliative care. Whereas I personally think that MD palliative, there should be a training for performing interventions in MD palliative medicine and palliative medicine fellowships also. So with this delivery of services, it's very important we have an education and training going on at multiple levels within the institution and outside the institution. It's very important to have a research and evidence building. One of my icons, Dr. V. Shanta from Adya Cancer Hospital, she said that research is not what happens in the laboratory. It's very important to study your patients, to see how your interventions are working, to see that what needs to be adopted and what needs to be adapted. It's very important to have a continuous audit going on at regular intervals to look at the effectiveness, to look what are the side effects, cost effectiveness of these services, so that an ongoing quality improvement goes on and ongoing modifications are required so as to have a more to provide better services to the patient. Documentation, research, and quality improvement is very important so that in future lectures such as these, more interventions can be brought forth for the efficacy of interventions apart from just celiac plexus and neuraxial analgesia. And the living example is from the AIIMS Delhi. If you look at the PubMed or Scopus search, they have done a wonderful job in coming up evidence available for various interventions, be it ultrasound guided celiac plexus block or neurology superior hypogastric plexus block. So I would like to conclude that yes, interventions, they are an important modality for management in a significant subset, that is 10 to 30% of the cancer patients. These patients do suffer from non-cancer etiologies, which may be better managed by a pain specialist. There is empirical evidence which suggests the efficacy of apart from traditional or the salvage therapy, it is very important that in early interventions, when they are indicated, they are performed so as to provide better pain control, improve quality of life. However, though we all know all these things, but the interventions we are often underutilized and withheld until the very end of life when they may not be very effective. So it's very important that close integration is, the close integration is important. Co-location of the services will help in interdisciplinary training and teaching. There's a need for a more interprofessional understanding of the skills so that the pain physicians are not just considered as the needle jockeys or someone to call upon in the last stage of the illness. And a thorough exploration of the roles and functions is important. At the same time, it's very important that anesthetists or pain physicians with special interest in cancer pain, they get adequate time and resources by the administration within the hospital to allow them to be involved at an early stage. We pain physicians always keep on saying that we are not needle jockeys, but it's very important for us to also keep in mind to have that palliative care is not just pain management and pain management is not just interventions. We should adopt an holistic management or a total pain approach as promulgated by Dame Cicely Saunders. And there is always a real person with the real fears, concerns, and psychosocial issues at the end of our needles and fancy gadgets. Thank you so much. Questions are most welcome.
Thank you, Mayank. That I think was a very, very exhaustive talk, and I think you've covered a very wide canvas. Arun, can I request you now to look at the questions in the chat box?
Yes, thank you. There is one question about celiac plexus block. What is the quantity of medicine which is used for celiac plexus block, and how many times can the block be repeated? Means at what interval can the block be repeated? Also, there is a second part to the question. Should diagnostic block be given prior to a therapeutic block? Thank you.
Thank you, Arun. So I will take the last part of the question first. I always do a diagnostic block before a therapeutic block because there is a reason. In some patients, the disease may be encasing the celiac plexus per se, and when the diffusion of the drug to the celiac plexus may not occur. So it's always advisable to do a diagnostic block before a therapeutic block. Secondly, how much ml of the drug is important, that will depend upon a lot of factors. For example, you're using either CT guidance or fluoroscopic guidance or ultrasound guidance. The more sophisticated a modality is, and the more the needle is an approximation with the celiac plexus, the less is the requirement of the drug. The second, what was the other question? I think so this question was asked in the last presentation also and was very well answered by Dr. Mahesh. And most of us would agree that we have stopped doing a neurology. We have now shifted from a celiac plexus neurolysis to a splanchnic plexus neurolysis, because then the involvement of the celiac plexus by the tumor has less of an impact upon the pain relief. How many times can it be given? So for pancreatic cancer, we know that it's a very malignant tumor. The life expectancy is not much. However, we have seen patients who are coming up having a significant pain relief at 3 months, and I have repeated at 3 months. I have not repeated more than 2 months. I would, if anybody else from the forum has done that, yeah, happy to share. So yes, it can be repeated. There is no limit as to the number of times it can be repeated, but just because the patients do not have a sufficient life expectancy, that most of us have repeated it multiple times. And if it is not effective in the first time, there is no point in repeating it after a week or after 2 weeks or 3 weeks, because the first time it was not effective if it was not an inappropriate approach.
Thank you. The next question is about sphenopalatine block. So the question is, explain the technique of sphenopalatine block by caregivers.
Okay, so sphenopalatine ganglion block in the community setting, there are usually 3 approaches. However, when it is done by the caregivers, it is usually the transnasal approach. So patient lies in a supine condition with the head little extended. You take a long nasal pledget with local anesthetic soaked distal tip and apply it perpendicular to the floor of the nose, because when you go perpendicular to the floor of the nose, then the needle, then the pledget tip usually rest at the base of the middle turbinate, and at the base of middle turbinate the SPG is just few millimeters away from the nasal mucosa without any bone. So it's just a simple procedure. You put a long nasal pledget parallel to the floor of the nose so that the tip rests. When there is a resistance, then stop. Do not push against the resistance. When you get the first resistance, stop.
Thank you. The next question is poor general condition of a patient a contraindication for interventions?
Okay, no. Poor general condition, I think so it's meant by poor performance status. So for example, if I talk about neurolytic celiac plexus block, so some of the good indicators or predictors are that patient should have a better performance status. Patient should be on lower dose of opioids. Patient should have lower tumor markers, meaning lower disease burden. So these are some of the good predictors. There is no absolute contraindication or even a relative contraindication that they cannot be done in poor performance status. But patients who have poor performance status, some blocks have not been found to be that much effective, such as celiac plexus block. I hope I answered the question.
Yes, yes. Thank you. There are no further questions at this point of time. If there are any questions, kindly put it in the chat box. Yes. Question. There is a question. If celiac plexus itself is a metastatic disease, can celiac plexus block be done or indicated?
I think so. What it means is that if the celiac plexus is involved by the disease, then is it indicated or justified to do a celiac plexus block? So as I have already said, that if the celiac plexus is being encased by the tumor 360 degrees, then whatsoever local anesthetic or neurolytic agent you are going to put, it's not going to reach the nerves or the plexus per se, and it won't be effective. But it does not mean that you cannot do anything else. You can do a splanchnic nerve neurolysis, which may be either by alcohol or radiofrequency ablation, because splanchnic nerves are usually posterior and they are free from the tumor. So if the celiac plexus is involved, then don't go for a celiac plexus block or neurolysis. Instead, go for a splanchnic plexus neurolysis or radiofrequency ablation. That's why it's always indicated to review the CT scan findings and take help of your radiology friends to see whether the celiac plexus is free or not prior to embarking on any celiac plexus neurolysis.
No further questions, sir. Nagesh sir, I think you can conclude, I guess.
Right. So thank you very much for a wonderful talk, Mayank. And we look forward to more and more such integration of interventional pain relief and palliative care in other institutions. I know what pain is, having undergone avascular necrosis on both my hips, and in fact, just prior to my surgery, my wife gave an epidural, and for those 15 minutes that I was waiting for the surgeons, I was literally in heaven. The spasm gone, everything gone. So I think that's very good. And I think youngsters who are working in different palliative care centers, I think should get together. And I think people like you and Mahesh and others, Mayank, should do something actively, okay, to see how you can integrate and how you can support these people so that the expertise that you have and that you're providing to your patients is available to others also. So thank you very much, everybody, for joining. Have a very safe week. Please don't do anything stupid. Please wear your mask. Please have social distancing. And basically, please stay alive. Okay? God bless everybody. Thank you very much.
Stanley, sir, want to ask something.
Can I just, sorry about this late question. Mayank, any role in managing people at home, with the ultrasound guided something, can this be done if they cannot come to the hospital? That kind of situation.
Sir, in India, I fear not, because when it comes to ultrasound, the PNDT Act is a hindrance. So as per the PNDT Act, an ultrasound machine is for a designated space. So there is a problem in moving ultrasound machine even from the OT setting to the ward. So I don't know if somebody is doing ultrasound guided blocks at home. And secondly, ultrasound, any intervention, it's important that it's done in a controlled environment where there are which is that asepsis is properly followed. There is resuscitation equipment which is possible. For example, in celiac plexus block, because of sympathectomy, patient may go into hypotension. So it's very important to preload the patient, and if patient goes into hypotension, to start giving fluids so that the patient can be brought out of it. So because of this PNDT Act limitation and the requirement of asepsis and resuscitation requirement, I have not done anything except for sphenopalatine ganglion block at home settings.
Yeah, I think what Stan was trying to get at is how much of support and sort of help can we give in a home care setting. We would like to do everything at home if possible, I know, but there are practical limitations, and particularly with the the PNDT Act, it is absolutely terrible. Anyway, good luck to everybody, and take care.